clear about the subject. Still, infantile colic is an idiopathic cause. There is no clear cause. But as we study about, for example, celiac disease, let's speak about celiac disease. Celiac disease continued for a long time, considered as idiopathic cause, and until 1953 or 54, all the strategies for treating, for example, celiac disease was either eating only mussels, eating only banana, eating only something, but they don't know what is the cause of celiac disease. Until the Second World War, after the Second World War, a village in Netherlands, there was throwing the bread through the airplanes to them, because there is no food after the Second World War. And one time, they stopped throwing breads to them for 6 months. So those patients with celiac disease was cured, and this was the clue for the knowing the cause of celiac disease. So now let's go through this presentation and know what is new about infantile colic. First, we see this small video about a child with infantile colic. So the mother, whatever she do, she will not stop crying. Let's go quickly about this case. 42 days old female brought to the ER at 10 p.m. with a chief complaint of extreme fussiness. Her parents think she has abdominal pain and she is gassy and pulls her legs up as if she is trying to stool. She passes a lot of gas from her rectum and her parents can hear her stomach gurgling a lot. Tonight, episode has lasted for 4 hours with intractable crying, and her parents are very distraught. They have tried feeding, pacifier, rocking, burping, changing the diaper, and inserting erector suppository, but nothing happened. Further questioning revealed that since 25 days, this happens on a daily basis. Usually in the evening, but the baby usually cries for more than 3 hours. Now, how we evaluate? How we evaluate this case? First, we should ask about perinatal history. She was born at term with no perinatal problems or infection at the time of birth. Medications is very important because one of the causes, now we enter in the differential diagnosis of that crying, irritable child. Nothing, we should not jump and say this is colic immediately. Maybe they are giving some medication, like pseudoephedrine, for example. So, and then feeding. What is the feeding? What formula? Breast or bottle or combination or what other things they are giving to him? And then the important no vomiting, no fever, no apnea, no constipation, no seizure activity or trauma, no history of shaking or abuse. And this patient has been normally in between the episode. This is very important to ask. How is the child in between the episode? He is well, playing, happy, feeding well, or he is all the time having this crying. On examination, everything was good. She is alert, active, vital signs normal, growth parameters very important. It was okay. Head, eye, and ENT as well normal. She was vigorously feeding during the exam. No signs of closed head injury. Neck, heart, and lungs examination are normal. Abdomen is soft, not distended. There is no different tenderness. Bowel sounds are active. She has no inguinal hernia. No tourniquets. If anybody of you saw tourniquet before? Tourniquet. If you see it once, you should look for it at any time the child comes to you with irritability and crying. Color is good, no color. Okay. Now the diagnosis, let's say this is infantile colic, but what is next? Can we share our practice, what we are going to do for this child? For example, any of you coming this child to him? Let's see.
Formula for colic.
Yes,
formula for colic or some colic medication.
So what colic medication are you using?
We can use prebiotic like Biogaia, for instance.
Biogaia, okay, good.
Or Cyanoticone as needed.
Or Cyanoticone. What else? Yes?
Timing of feeding. We should regulate the space.
Arranging the time of feeding. So the feeding technique is arranged. Good. This is another modality.
Encourage breastfeeding also.
Sorry?
Encourage breastfeeding.
Encouraging breastfeeding. Okay. What else? Huh?
Proper burping.
Proper burping. Okay. What other practice?
Try to decrease the milk product in the mother, right?
You mean encouraging more breast?
Yes, breastfeeding, but the mother adjust her food, decreasing the milk product.
So good. So low allergenic mother food. She's suggesting low allergenic mother foods. What was the allergenic mother foods you are suggesting?
Yes, not only the allergenic, also the thing that cause excessive gases. And
For example?
Yes.
Dairy products.
Fried.
Dairy products. What else?
Product, yes. Protein, meat of cow and like this. Also, we can decrease it.
Meat of cows?
Yes, decrease the product of cow, whether the dairy product
or the meat. Okay. It is only mentioned the dairy products, eggs, fish, and nuts. This is the things that we have. Okay. So we have experience like using anti-colic formula with Simethicone and low allergenic diet for the mother, and also nobody using herbals. Okay. So let's see in this next slide, what is the fact behind? What is it true? What is correct? What is hard evidence for that? So now crying is a paroxysmal excessive crying without identifiable cause in an otherwise healthy newborn infant. This is the other names. For example, cry phosphatemia, period of birth or crying. Whistles in 1954 classified infantile colic and put a criteria, sorry. Is it 3 hours per day, more than 3 days per week, more than 3 weeks, more than 3 weeks, and most of the other classification, it must be started before 3 weeks, other classification. Crying is a regulatory function. It helps in regulate our body temperature. It's also a form of communication, increase motor activity, and also increase lung expansion at birth. This is the normal crying curve. When the child delivers, the normal crying should be 2 hours at the age of, for example, 2 to 4 weeks, and they peak at 6 weeks. This is the maximum. He should not exceed 3 hours, and then start to decline after that. This is the curves. There are 4 curves. This is what we call it the acquired baby, this curve. He will only exceed a little bit 60 minutes per day. This is the normal, the green one, the normal child. He reached the peak around 2 hours something at the age of 6 weeks, and then try to drop. And this is the colicky, normal colicky, and this is a severe colic. So we can compare the colic, which is the regular colic. Again, it's peak between 2 weeks. Sorry, yes. Start to increase after 2 weeks, and peak between 4 weeks until, let's say, 8 weeks. But there is a group of children, we call it colicky for 15 weeks. This is a severe form of colic. Those who are needing more intervention are very disturbing to their family. This is a very nice job done by Whistles in 1954. He classified arranged what is the time of peaking of the crying. It's not after 1 a.m. and like that. No, it is from 5 until 11. This is the time of maximum crying. Okay. How long does the colic last? It must begin before 3 weeks and end 50% by 2 weeks, 80% by 3 months, and 90% by 4 months. epidemiology, it ranges from 8 until 40%. It depends on the culture, the community, the high index of suspicion. Some cultures consider it as normal. They will not care if the child is crying a lot. They consider it normal. So for that reason, there is a wide range from 8 to 40%. It is the same between male and female, breast and formula fed. So there is no difference between breast and formula fed. And full term and preterm, they have the same risk. What is the potential sequelae? We said this is normal. This is normal crying. It will not harm the child, but will make the mother really who are waiting. She's waiting for a baby, make her crazy. All this baby is crying all the time. She prepare a new bed and new clothes for him, and they are happy for the baby. They are seeing a photo of the baby, but this baby is crying all the time. So what will make them? Parents stress, fatigue, guilt, and depression. Risk of postpartum depression and early cessation of breastfeeding. Disturb the child-parent interactions. And then they could have a butter baby syndrome. Those who are shaking all the time, they are thinking that by shaking, he will be calm. And so this study, they found that 2.2 to 3.7% at least slapped or shaking their baby vigorously. This is in a Western, sorry, I didn't put the reference by mistake. This is in a Western culture. You know, when they are saying, yes, I slapped my baby, it's like somebody saying something very, very severe. In that culture, it's very hard to say, yes, I slapped my baby, or his baby is 2 months. So there is a risk of shaking baby, of hurting to the baby from the mother. The clinical features, it's a paroxysm, clear beginning and a clear end, nothing in between. Qualitative difference, the cry is louder, higher, and more variable in pitch. It's like somebody telling, I am having something, somebody shouting for help. As we say in the movie, hypertonia, facial flushing, circumoral pallor, tense or distended abdomen, drawing up of the legs, clenching of the finger, stiffening and tightening of the arm, and arcing of the back. He's little raising his legs. Difficulty to console. Whatever you are doing, it's difficulty to console. Little water, please. Okay, now the etiology. We should consider in the proposed etiology these factors: the age of onset, individual variability, the non-random distribution, why it is at the end of the day, not on the night after 1 p.m., and the spontaneous resolution. Now, there are many, as we said, we put at a proposed etiology. The etiology is unknown. But as we said in the beginning, like in celiac disease, or there is something near close. They know that there is something in the diet, but till now, they didn't know what is exactly the cause for that. So, for the cow's milk protein, or the gastrointestinal, for the gastrointestinal etiology, the cow's milk protein, a subgroup of infants with colic have symptoms that are caused in part by allergy to either casein or whey, and have a significant reduction in symptoms within a few days of initiating hypoallergenic diet. Okay, example, protein hydrolysate formula. Available evidence suggests that colic potentially has a number of independent causes, including dietary protein hypersensitivity. And there is a systemic review of a medical literature regarding the effectiveness of various management strategies for colic. They found in these two systemic reviews of the studies that whey hydrolysate milk likely to be beneficial. Other gastrointestinal etiology, which is proposed as etiology, lactose intolerance. Effect of lactase on infant colic were evaluated in 2 randomized controlled trials. Neither study found a significant difference between the treatment and the placebo group. So lactose intolerance plays a minimum role, if any, in the development of colic. So this is already cancelled as a proposed etiology. Until hypermotility, intestinal hypermotility secondary to presumed autonomic imbalance also has been proposed as an etiology for colic. The evidence for this hypothesis is contradictory. The gastrointestinal immaturity, another theory, proposed that colic is related to incomplete absorption of carbohydrate in the small intestine. Unabsorbed carbohydrate fermented by colonic bacteria lead to excessive gas. The evidence for this theory is inconclusive depending on these studies. Now, we come to the microflora. The child is supposed to be delivered by sterile gut, but in fact, the meconium are populated with E. coli and lactobacillus. By 7 days of age, 2/3 of formula fed have a predominance of bacteroids, which is non-beneficial bacteria. It can cause appendicitis, appendicular abscess, it's completely the beneficial bacteria. So, but bacteroid colonize 22% of breastfed infants. At 1 month of age, breastfed infants have a bifidobacterial predominant colonization, whereas formula-fed infants have equal colonization between bacteroid and bifidobacteria. Bifidobacteria is a very famous probiotic present in, for example, Activia. This is small yogurt, thick yogurt. The colicky babies have a significant fewer beneficial bacteria than non-colicky patients. We can see that the colicky have a less lactobacillus count than those control group. So, the intestinal microflora studies have demonstrated, all these 4 studies, demonstrated differences in intestinal microflora between infants and colic. With colic and control infants, particularly Klebsiella species, anaerobic gram-negative bacteria, coliform bacteria, E. coli, and lactobacillus species. In one study also found a 2-fold increase in fecal calprotectin. It is a marker of intestinal neutrophil infiltration among colicky infants compared with the control one. And the role of fecal microflora in colic is supported by a randomized trial, as we will see later. The other proposed etiology is the biological factor. As our colleague said, that the feeding technique, underfeeding, overfeeding, infrequent burping, and swallowing of air, all have been described as a possible etiologic factors. But actually, this is not supported, it's not a solid thing, because as we will see, whatever you are doing, all these techniques, it's doing a very little for the colicky infant. So the motor regulation, many of the mechanisms that regulate motor activity are immature. The immaturity of this mechanism may result in increased vulnerability to feeding intolerance. So other biologic factors which is proved to be increase the risk, like tobacco smoke and nicotine exposure. Maternal smoking during pregnancy or in postpartum period has been associated with increased risk of colic. And also, there is a very interesting studies about early form of migraine. Observational studies in which a history of infantile colic is more common among children with migraine, and they suggest that infantile colic may be an early manifestation of childhood migraine. Other proposed etiology is the psychosocial, the temperament. In one controlled clinical trial, when parents of colicky infants were consulted regarding the effective responses to crying, how the mother responses, the crying decreased from 2.6 to 0.8 hours. Hypersensitivity, another proposed hypothesis is that crying at the end of the day, why we said it's mainly at the end of the day, not in the morning, from 6 p.m. until 11 p.m. Represent a discharge after a long day of exposure to environmental stimuli and is a means of maintaining homeostasis. This is suggestive hypothesis only. Parental variables, various parental psychosocial factors including family stress, maternal anxiety, and transmission of tension from the mother to the infant, have been proposed to be associated with colic. All this is theories, actually, is, nobody talk about it, but I searched for it and I found it mentioned about theories of colic. Now we want to evaluate the child of colic. What we are going to do, typically suspected based on history, must be differentiated from other conditions. What other condition we must differentiate? Interception. Good. What else?
Cow protein allergy.
Excellent. Cow's milk protein allergy. Very important because it's a chronic thing. For interception, it's usually short, 1 day, 2 days, like that. But cow's milk protein allergy, usually, what else?
Lactose intolerance.
Could be. What else?
Other causes of excessive crying.
Good. Other causes. What are the other causes?
Infection.
Very low. But a very common problem we are facing is reflux. It's a very common problem which can face a lot. Gastroesophageal reflux could present with a prolonged crying. Okay. So feeding, we should ask about feeding. What is the type of feeding? How much the amount of feeding? Stooling, maybe you have constipation. Urination, amount of urination, because it could be a sign of poor feeding. Decreased urination. Sleeping patterns, how is it sleeping well? Important. How and what do you feed the baby? As we say, underfeeding, overfeeding, underfeeding. And medication, always ask about medication. Sometimes this is the cause of excessive crying. One time, the Dorinase 2.5 and I was given for 3 months or 4 months. 2.5 contains pseudoephedrine, very high dose. And he was irritable all the time. They don't know what is the cause of his irritability. So on examination, we are concentrating on what things. Okay, first observe the child. Observe how is the parents dealing with. Maybe from the start, you are not happy about the way of the dealing of the parents. Maybe the parents are not dealing well with the child. So concentrate on the handling of the mother. Growth parameters must be plotted. Hydration and subcutaneous fat, because loss of weight could be a sign other than the colic. Tongue tie could be associated with breastfeeding problem. Eye examination for any other pathology, abrasion, for foreign body, like that. Ear examination for otitis externa and media. And oral pharyngeal examination for any region or thrush. Now, the cardiovascular system could be SVT. Patient could present with prolonged crying. If you have SVT or heart failure or acute, by the way, acute bronchiolitis, I have many patients presented not with cough, crying irritability. Patient coming with crying irritability, and then when you ask, yes, he's starting to cough, and then next day cough, start to problem. And usually, I found those are young, having a reflux also. Coughing, and they have a gastroesophageal reflux and acidity also. And choking with milk. Abdomen, for tenses, tenderness, absence of bowel sounds. Perineum for diaper rash, torsion or tourniquet of the penis, or meatal ulcer, renal fissure, inguinal hernia. Skin and musculoskeletal system for trauma, bruises, or injury, and CNS. This is a list of differential diagnosis of chronic irritable child. Okay? And then, what is in the history? A red flag in history, which means this is not colic. We should consider it that fever, paroxysmal irritability, paradoxical irritability, means when the child is lying in the quiet, when the parents holding him, he started crying. When they put him on the cot, he stopped. This is paradoxical, this is against colic. Okay? If there is any history of the perinatal infection or prolonged rupture of membrane or like that, maternal drug use, drug-without syndrome, poor feeding or poor weight gain, significant decrease in level of activity, or cyanotic or apneic spells, or bilious or projectile vomiting, history suggestive of classical infantile colic syndrome, history suggestive of physical abuse, antibiotic, pre-treatment, maybe partial treated, Now, what is the red flag in the examination could be fever, as we said, hypothermia, heart rate more than 230, lethargy, poor eye contact, paradoxical irritability, pallor, marking of poor perfusion, weak pulse, hypotonia, peak hemorrhagism, and so on. This is, other than everything you are seeing is normal, abnormal, consider it away from the colic. Because colic, everything is normal, other than these crimes. Okay. Now we saw the hypothesis and we saw the proposed etiology. What we are going to do? Shall we leave him alone? Shall we do something? We must do something because the mother will not accept that you will tell her that this is self-limited, it will not harm the child. She wants her baby to be quiet. So the first thing is the first line intervention is the feeding technique. Okay, timing and of the feeding, and the amount and everything. But actually this one is, evidence is limited, but it costs nothing. I'm not harming. Always right is right. And when you told them this is good, this is the same good, and you try to use a curved bottle because it will decrease the swallowing of air. Okay. The first line, the other way is the soothing. The soothing technique, there is a list of soothing techniques, as we say. You can use any one and try it. If it does not work, try the others. Even someone suggested to open the washing machine. Then when the child listening to the washing machine, they stop crying. Or hair dryer, or like that. So try whatever you want to try first, and then see. Maybe it works, and maybe not. For the saccharose use, you know saccharose is used as an analgesia for insulting IV line or in pediatrics. But there is no evidence for it in colic. For the lactase, as we discussed at the proposed etiology also, it is not suggested. All these trials are not suggesting the benefit of the lactase. For the infant massage, there is a systemic review. They found no evidence of it. The Silicon in 2012, a systemic review of small randomized trials with conflicting results found little evidence to support its use in the treatment of infantile colic. It's a safe medicine. It only interacts with the L-thyroxine, the one used for hypothyroidism, the thyroxine, but it's a safe. You can offer, no problem. But what is the end? What's the benefit of using it? A systemic review of medical literature regarding the effectiveness of Silicon unlikely to be beneficial. The two systemic reviews, they found it not. The anticholinergics, because there was one medicine called dicyclomine, the Bentil. It has been associated with apnea and no longer be used in an infant less than 6 months. And also there is another one which is called simitropium. It was widely used in Italy. Showed a decrease in the duration of crying crisis with the treated group, but they have sleepless patient. Seriously became sleepy, so it's not suggested also. This is a new Nepal dotant pharmacological agent. They are studying it in a multi-center, and they are starting in phase 2. Phase 2, what is phase 2? Anybody knows what is phase 2? Phase 1 is microdosing. They are putting the dose of the drug or the vaccine for a trial. Phase 2, they are trying on a small group. Phase 3 is trying on a very large population, and then it will be in the market. So a cochlear review on pain relieving agent is in progress. Maybe it will help in the future. The herbal, it is not suggested. Why? Because a lot of standardization and regulation of herbal products. Benefit do not outweigh the potential risk, like contamination with bacteria, toxins, or particulate matter, unlabeled ingredients like alcohol. Prolonged ingestion may increase milk intake. So it's not suggested. And also increase the risk of allergy. Some child are allergic to The manipulative therapy, they go far. They make a clinic for manipulative therapy. I saw a video, I have it, but there's no time to show it to you. A clinic in Dubai, child with infantile colic coming to them, they are doing like that, and alignment of the cervical column, and then another sessions. Meanwhile, the patient is growing up, and they said he's improving. And they told him that there is malalignment of the vertebral column, and they are happy. And making an interview with the mother, yes, my child was torticollis, but they didn't say torticollis or something like that. They said that the vertebral column is not good, so they make my baby happy. So what's called chiropractic treatment may offer short-term reduction of daily hours of crying compared with non-treatment or placebo, but no long-term benefit. Yani at the time, they may have some very short-term, but for a long-term or on the next hours of the day, there is no benefit. Okay, so this is acupuncture. A standardized light stimulation of the acupuncture of what's called LI4 or LI4 twice a week. This area, for 3 weeks has shown a reduction in the duration and intensity of crying with no serious reported side effects. This is depending on this study, but a recent study has reported no significance. I don't believe all these things, but this is all mentioned. I want to show you all what is mentioned about colic. It's everything they are talking about. Behavioral intervention, there is a many study, but also it's questionable. Now we'll come to probiotic. Probiotic, over 10,000 years back, people drinking fermented milk. In 1899, Tresor discovered the bifidobacterium in a breastfed infant. In 1907, Eli Maknikov, an Russian scientist, he's a professor in Pasteur, he was interested in the Bulgarian descent. He said, why these Bulgarian people living more than Russia, more than France? There is something. And he found that the Bulgarian people drinking a milk fortified with bacillus, and this isolate the bacillus and produce a milk and say this is a Bulgarian bacillus fortification. I think he was working marketing for himself. In 1917, Alfred Nessel discovered what's called Nessel 1917. He was in a camp of soldiers, German soldiers. All of them have an outbreak of shigellosis. He saw one soldier from this camp didn't got shigellosis. Why this guy is with them, drinking the same water, eating the same food, helping them, and didn't got shigellosis? So he brought this guy. He isolated an organism. It's called E. coli. It's the only probiotic E. coli. It's called Nessel 17. And he treated those people with this E. coli, isolated it from these soldiers, and give it to them and to treat shigellosis. So he was one of the considered man who used probiotic here. But there was nobody saying this is a probiotic. The term probiotic was first considered in 1965 like that. And then later on, gradually people focused on it over the last 20 to 25 years. There was many studies about probiotic and its use. And now, for example, there's a comparable study of using for the ulcerative colitis. I have found a study of using probiotic for ulcerative colitis and for H. pylori and so on. So for lactobacillus rhamnosus, I think the other presentation will be more details. It's present in all the GI, from the stomach until the colon. The effect, which is mentioned already, I'm talking about it in the text, that it can produce protein, which inhibits the growth of some harmful gram-negative and gram-positive bacteria, along with the fungi protozoa. Treatment of rotaviral diarrhea is very commonly used to treat trials. I don't remember if it's on rotary or another probiotic to prevent children attending daycare center from getting rotavirus diarrhea. And it suppressed H. pylori, as we said, infection. For the oral health, it's proved to kill Streptococcus mutans, which is responsible for tooth decay, and gingivitis symptom decreased by its use. And also for the general health, double-blind randomized studies in child care center have shown that this probiotic fall sick less often. Those patients who are taking infants have sick less often, require fewer doctor visits, and are absent fewer days from the daycare center compared with placebo. And the safety, it is tested for tolerated to be tested in children, health adults, and immunocompromised HIV patients. And there was no any side effect reported. In this study, you can find that the probiotic for infantile colic are randomized, double-blind, placebo-controlled trials investigating Lactobacillus rotariae. 55 infants are assigned to take either placebo or Lactobacillus rotariae. And they found that in Lactobacillus group, the minutes of crying per day on day 7, it was decreased to 90 minutes in comparison with placebo. It was 120 minutes. And at 14 days, the Lactobacillus group was 75 minutes, and the placebo was 103. And by 21 days, it drops to 60% in those group Lactobacillus rotariae in a comparison with 102 and the placebo. This is another study in a breastfed colicky infant showing that the minutes of crying by 28 days it drops to 21 minutes per day in Lactobacillus rotariae group in a comparison with 145 minutes those taken with the significant. And the response was 95% who were taking the probiotic and only 3% who are taking significant. This is also for a comparison with the breastfed and the bottle-fed. Those are taking placebo and those are taking Lactobacillus, what's called comforters. Now what I found in this journal of Italian Journal of Pediatrics, as we can say that there is high evidence of benefit from hydrolyzed milk in some group of infantile colic. So what they suggest they suggest a dietary changes. It should be discussed with the mother that this could offer a benefit to your child. So for the standard formula infant who's taking standard, switch to standard infant formula to special formula based or partially hydrolyzed whey protein with a prebiotic oligosaccharide or formula containing probiotic. So switch to this and give a trial of 2 weeks. If have colic symptoms improve, you will continue. If no, you can also again discuss with the family. We need to switch to extensive hydrolyzed, but it's very expensive and have the worst tests in the world. So the very bad test of extensive the milk test. So after 2 weeks, if the symptoms didn't improve, return to the standard formula. This should be with educated family. Talk to them. They will not accept, oh, you are giving a trial to my child, you are making it. You should explain to them. This could offer a benefit and decrease the symptoms of your child. Because not only the cow's milk allergy, not always you are seeing them severe, fear of deprived, not drinking milk. Some there is a mild symptoms. So they could have a benefit. For breastfed, as the doctor, I don't know what the doctor suggested, to have a low allergenic diet. No milk, no eggs, no nuts, no wheats. Wheats also wheat. It's considered. So particularly if the mother have a atopy, atopy, or the previous child had atopy. So follow for 2 weeks. If it effective, continue. If no, start taking the probiotic. And after 2 weeks, if improvement, continue. If no, consider administration of pain-relieving agents. In Italy, they consider this in this article to use it for a short time. Now, let's quickly go in 5 minutes.
No, it's okay.
You see this, the last case, you see this, what does this child have? Excellent. So this child, he don't want, he want to making sandified or tetanus, so he don't want to drink. Okay, so this is a quickly, I put it as a differential from the colic. We should differentiate between these two. So this is 45-year-old male brought to OBD with his parents with complaint of constant irritability and spitting up, perinatal history, birth weight 2.8. Okay, he always seems to be hungry, and since his mother is certain that he is not producing enough milk, she has been following by breastfeeding with formula for the last 2 weeks. He currently will feed at the breast for 10 minutes, then consume another 4 ounces of bottle. So he's overfeeding. Examination, cardiovascular unremarkable, but he's gaining weight. So what is the diagnosis of this child with gastroesophageal reflux? We want to consider it as a differential diagnosis. It's very common, and sometimes both symptoms happen. If both symptoms happen, we may consider cow's milk allergy more. Rough spitting, with colic, continuous colic, we may consider, but usually they have eczema. Usually the child with infantile colic, with cow's milk allergy, have eczema. So at the end, I want to tell that these scars tell a story of pain, but the moral of the story is I got up again. It's only a pain which, and the child will resolve all this. Thank you for your attention.
Time for questions, or can we switch, and after that for questions?
We will be having like 10 minutes coffee break.
Okay.
And then
so the question will be at the